Hello and welcome. Can everyone hear me, see me okay? Yeah, we're all good? Okay, perfect. Okay, I just want to make sure everyone's here. And if you just give me a minute here. So welcome to the 2024 Drug Treatment Court Conference organized through the Association of Justice and Treatment Professionals. My name is Jennifer Lysey and I'm a member of the association and I'll be your moderator for this session. Please be advised that this session is being recorded and a copy will be provided on the association's website, as well as a copy will be provided to you shortly after this presentation. Today we have Allison Perry-Raslovich, Jeff Gauthier, and Teresa Laskowitz joining us from Lake Ridge Health and the Mental Health Program to discuss early psychosis intervention, the who's, the views, and Form 2s. Before I begin, I would like to read out our land acknowledgement. We will begin by acknowledging that we are meeting on the Aboriginal land that has been inhabited by Indigenous people from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all generations of people who have taken care of this land for thousands of years. Long before today, as we gather here, there have been Aboriginal peoples who have been the stewards of this land. In particular, we acknowledge the and I apologize for pronunciation, Anishinaabe, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples. The land is home to the Métis and most recently the territory of the Mississaugas of the First Credit Nation, who are direct descendants of the Mississaugas of the Credit. We recognize and deeply appreciate their historic connection to this land. We also recognize the contributions of the Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community in particular, and our province and country as a whole. As settlers, this recognition of the contributions and the historic importance of the Indigenous people must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our committees, and in particular, to bring justice for the lives lost in residential schools, as well as all the murdered and missing Indigenous women and girls across the country. I will be monitoring the chat throughout the session. Please, if you would like any kind of clarification, please put it in the chat, and there will be time at the end for you to ask any questions that you would like of the presenters. And I will let you guys take it away. Oh, Allison, I'm just going to see, you guys are muted. Are you able to unmute?
Okay.
There we go. Thank you.
No problem.
Right.
Sorry, we thought you muted us, so we thought you were going to unmute us. Or anyway, we'll just continue as we are. Okay, let's get back into this.
All right. And slideshow from the beginning. And down the very corner. There's always technical issues.
Oh, yeah. Okay, so I'm very glad that we were invited to discuss early psychosis. I think it's a very timely issue. I think we're seeing a lot more of it in the news, and certainly in healthcare, we're seeing a lot more of it. And I'm sure that people in the legal system are also seeing a lot more of it. I think part of the reason that we're maybe seeing an increase is due to changes in legislation for cannabis. So from October of 2018, having legalized cannabis, I think, has allowed a lot more people to use cannabis, and as a result, sometimes experience psychosis. And also we've gone through a pandemic and a lot of stressors as a result of that. Cost of living increases, housing crisis, and a lot of reliance on digital technology. So I think we're living in different times, and I think as a result, there's a certain level of paranoia with digital technology that exists. So I think it's important to acknowledge that. So we'll just get going then, and I'll talk a little bit about the outline. So what we're going to do, first of all, I'll just describe what psychosis is. What are some of the risk factors? Some stats, some protective factors, the EPI movement, what that actually means, and some of the challenges that we face. As well, we know that people with mental health challenges are more likely to be victimized than to be perpetrators of crime. They continue to be overrepresented in the criminal justice system. I believe the stat is like 40% of people in criminal justice have a mental health. Jeff will talk about the risk of violence and suicide and how this relates to people with psychosis. Teresa will discuss the challenges faced by families, the use of LAIs, long-acting injections, to assist with medication adherence, and a little on some ideas for navigating the challenging mental health system. So I'll take you through what psychosis is. So it's a symptom which is described as a loss of touch with reality. It's really hard to define psychosis exactly, perfectly. There's a real negative connotation to even the word psychosis. A lot of people struggle. I know when I used to start calling to do intakes for people, if I said I was calling from the early psychosis program, I would almost inevitably get like, I don't need this. So I kind of learned our name is actually called Derma Maze. And I guess part of the reason is if we said what we actually did, people would not want to be associated with our program. So it's definitely a scary term. The way we describe it though is it's a symptom of something. It's indicating there's something else going on. That symptom itself can be caused by lots of different things. It can actually happen if you don't have sleep for a period of time. You can actually have a psychotic episode, or at least have a little slight hallucination. That can certainly happen to people. They've done studies where they've had people not sleep for 5 days. And that's certainly something that you can cause to happen. But generally, most people don't experience that. I think in the past, we might have heard of people talking about like having a nervous breakdown, going into hospital for mental health issues. They would say they had a psychotic break. Most people don't say I was in the hospital because I had psychosis. So psychotic break is another older kind of definition, but I think we have to take a moment to think about like how many people do you know who've experienced psychosis? You don't have to answer, but just as a sense, if you want to, please feel free to put it in the chat, and maybe Jen can read back how many people you think out of 100 would have experienced psychosis in their lifetime. And this stat actually surprised me. So I don't know if anybody's responded, Jen.
No, I don't have any responses yet.
Okay. No worries. Anyway, so I'll just give it to you. So about 3 in 100 people have experienced a psychotic episode in their lifetime. So it's fairly high. Like I remember just being kind of shocked by that stat when I first started with this work. In comparison, just talking about people who have diabetes, about 1 in 9. So it just 11%. So it just gives you a sense, like it's not that uncommon, less common than diabetes for sure, but definitely not that uncommon. There's a lot of people who've experienced psychosis. I'm sure you've probably all heard of Vincent van Gogh, an artist. I believe he had bipolar. Ernest Hemingway had bipolar with psychosis, and also he also had alcohol issues. And Sir Isaac Newton apparently had psychosis as well. So it's definitely been around for a long time. Many cultures have tried to define it and described it, all sorts of things. And it's just definitely something that has been there, but we changed the way we look at it based on like the DSM-5, which we are going to go into. But I just want to highlight, rather than the symptoms, which are definitely not enjoyable, they're very frightening. And so, you know, a loss of touch with the reality. So you're not really present. You're not really knowing what's going on. People are often questioning your judgment. You might say, I hear something over here. And do you hear it? No, I don't hear it. So it's a real strange and hard experience. The other part of that, though, is usually they end up in the hospital. And it's usually involuntary. And sometimes, depending on whether they fight it or not, they may also be in restraints. So that first kind of experience with psychosis is really traumatizing in itself. And a lot of times the work we have to do is actually looking at that and helping them kind of unpack that trauma of that experience. So I think it's important to consider that. It sounds so, for us, it's like, okay, it's just one symptom, it's one thing, no big deal, it's just like having diabetes or whatever, but it isn't. If your family member, like your young person, had gone into hospital for a sudden surgery, an appendectomy or something like that, chances are you're probably going to tell your family, your friends, you're going to get a little bit of time off, you'll get support, people bring you food and all sorts of things like that. When people go through this, they typically don't want to say that my kid is experiencing psychosis. They don't want to label their kid, they don't want to stigmatize them. They also usually are in denial themselves, like they don't even really understand it fully. They're just really shocked by the whole thing. So I think it's important to remember that it is a really hard situation. And often the first episode is triggered by a perfect storm is what I usually describe it as. So stress, lack of sleep, substance use, medications, certain medications for acne, for example, can trigger an episode. I had a client like that actually currently. And some other health issues can trigger it. Like there's some hormones that can trigger it. You can also have tumors, which can trigger. But usually when you have psychosis, those things are not present, but you definitely want to rule them out. So the next part, so we'll just talk about the DSM, and that is schizophrenia spectrum and other psychotic disorders. That's the name of the chapter it falls under now. It's a little bit different. It took me a little bit of time to actually get my head around because I'm a bit older. So I was actually trained on DSM-4. But anyway, so the abnormalities is usually having to show one of these things. So this schizophrenia spectrum can include schizoaffective and other disorders. It can include schizophrenia, obviously. And people do have brief psychotic disorders and substance-induced psychosis and all sorts of things like that as well, which can fall under those. And also schizotypal now, I believe, is also falling under that as well as a personality disorder. But the main symptoms are hallucinations. Now, in the old days, we used to say positive and negative symptoms of schizophrenia or psychosis. So the positive symptoms, just to get you to think about it, because it's still often referred to in a lot of articles that you might read or any books that you might read on the subject. So positive symptoms are something that's added onto a person's experience. Not necessarily a good thing, obviously, but hallucinations would be something that they wouldn't normally have. So hallucinations can be auditory, it can be voices, it can be sounds, it can be a stranger's voice, it could be somebody they know. It's not their own voice. It could be one voice, it could be many, it could be a kind voice, it could be critical. Like often they're kind of mean and they're sometimes trying to control them. We know sometimes people do actually get command hallucinations where they're actually told to do things. And that's when it's a bit scary, but Jeff may get into that a little bit more, I believe. Delusions are something, so it's a fixed belief that a person holds and they are not going to change their mind. So a lot of families do struggle with, there's nobody over there, there's no voices, this is not real, this is just coming from your head, and that actually escalates the situation typically. So with a delusion, you don't want to partner with them and say, oh yeah, I see it too, but you do want to, kind of help them understand how scary it might be. So delusions are a belief, so often they're not very pleasant. Usually it's a belief that I'm being followed, or that something bad is going to happen. They're just anticipating really not so good stuff. So the delusions can be bizarre. So some of the delusions could be that an alien came and got me and took my organs out. Obviously, that's not going to result in a live person. So it's definitely a bizarre delusion. They can also be non-bizarre, which it's not outside the possibility. So a lot of times the delusions could be that somebody's listening to me in my conversations. Every time I, listen to my phone, they play a song that's just for me, that kind of thing. All sorts of different aspects, but you could almost believable because our phones to some degree do pick up on what we say, the language that we use and the words we use. I'm sure everybody's had that happen where you've said a word and then all of a sudden you get a link about something. Anyway, so sorry, just to go back to hallucinations, I didn't mention that there's many forms of hallucinations, so it's all the senses essentially. So hallucinations, generally it's more auditory, but visual as well is a very common one. Some people see people, sometimes it's shadows or animals, fleeting glimpses, sometimes it's patterns that they see. Often, like, it'll be in the dark, they'll just see like a flutter and they don't really know what it is, so it may not even be something they could describe. But it's definitely very scary. Olfactory, so that's things, people smelling things that are not there. Again, sometimes they're pleasant smells, sometimes they're not. Gustatory, so they can taste things that don't make sense. So I had one client who was eating a chocolate chip cookie and said it felt like he was eating dirt. And that was his kind of experience of psychosis, as well as a few other things. He also saw stuff. Gustatory, so tactile, so feeling like somebody's sitting on the bed beside you, like somebody just sat down, even though you don't see anybody there. It could actually feel like you have bugs crawling in your body. Not a very pleasant feeling. A lot of clients I've worked with actually have pain. So sometimes it's a headache in one area. Obviously, you'd want to rule out that there's anything else going on, but sometimes that pain may be related to some trauma that they've experienced. So I've had clients who had pain in their groin and pain in their neck, like feeling that they're being choked. So it's not very pleasant, and those ones tend to persist, and I find them a bit harder to treat. I don't know if you guys have also experienced that. Anyway, so that's just to give you a sense of all the kind of hallucinations, and then the delusions. Like I said before, we talked a little bit about bizarre and non-bizarre. We have to also like listen to the religion. Like religion is a big part of delusion sometimes. So we've had clients who read the Bible every day. Their family may be religious, but they may not be that religious. So clients sometimes take it to an extreme level where they're starting to like preach certain things. I've had a client like maybe preach the Quran to people that they go to school with who are not necessarily from that religion. So stuff that would even kind of upset the family. As well, though, some religions actually do think that hallucinations are a normal part of their religious experience. So you have to also, appreciate that in the context of that. Did you want to say anything? Okay. So it's definitely a challenging one, and it's changed. I don't think that we see as much of the religious delusions as we did previously. Sometimes people would feel that they were a savior. They were sent here for a purpose to save mankind and that kind of thing. So sometimes it can be scary. Sometimes they're very harmless. They're not going to do anything. They're literally just trying to make people happy, spread the good word, that kind of thing. Sometimes people have delusions of grandeur. They think they're an Olympic athlete, or that they're super rich. Delusions of persecution, I think I mentioned that. Somebody's after them or is going to hurt them. Delusions of erotomania, so a belief that someone's in love with them. And it persists despite the fact they may not have any experience with that person. That person might not have even ever spoken to them. Disorganized thought, so we know that by their speech, obviously. So usually you'll see erratic speech, nonsensical speech. Sometimes it's not making any sense. They're not even using words. They derail, so they'll start with one topic and then they'll go into another, and they just all kind of meld into one another, and it's hard to tell what they actually said. Abnormal motor presentation is not uncommon. In the old days, I would say you saw more catatonia, where people would just stay in one position for a period of time or not move much at all. I would say now you tend to see more of agitation and pacing, sometimes grimacing. And then the negative symptoms, so when I was saying before about the positive and negative symptoms are the things that take away. So psychosis takes this away from a person's experience. So things that they would normally be. So a part of their personality, it could be their hobbies, their interests, and they might be very sporty and all of a sudden they don't want to play hockey. They might be involved in groups. They tend not to want to socialize. And sometimes it's that they don't want to socialize. Sometimes it's that they know if they do socialize, people are going to pick up on that something's not right with them because they get scared. Sometimes they laugh inappropriately. They seem to be responding to the voices in their head, and they'll have full conversations sometimes with them. So it's very scary and not very pleasant. I like to show this slide, although it is a bit old. The reason I show it is I think it really is behind the reason why we have early psychosis programs. So this is just a typical progression. So it kind of shows in terms of age, what it would look like. Now we tend to see people 14 to 34 is our age group that we serve. We tend to see people right at they just had their first episode. We try to capture people in that. That's the whole point of our program. What you typically see is pre-morbid, so just generally good functioning or normal functioning, near normal functioning. Sometimes you'll see a little bit of a dip in functioning during the adolescent years. It's hard to pinpoint what that is. what it looks like. A person's personality can change, but it also can change with adolescence. So it's often not picked up on, even though it might seem when you look back, you can usually say, well, I can pinpoint when this happened. It's just good to kind of be aware of that. We call that the prodromal phase of illness. So it's where functioning's affected a bit, but maybe not enough to trigger anything, but a bit that there's definitely a change that people notice. The person's not the same. They don't smile anymore. They don't want to watch movies with you. They don't read anymore, that kind of thing. And then often with the first episode, it's very scary, like I said before, and they end up usually in the hospital because it's pretty significant. To families, they may not be hospitalized, and to families, sometimes they're kind of surprised by that. And I think Teresa might go into that a little bit more. But, just in terms of risk to self or others, if there is no risk, even if a person is still having hallucinations, we're not necessarily going to be hospitalizing them for that. So that can be kind of scary, which is nice why we have our programs like this. Anyway, so just in terms of progression, though, and the rationale is that there's a typical pattern of a person gets sick, goes on medication, gets better, and then feels better, and then stops the medication, which of course we all used to do with antibiotics. We would all take the medication, and now we have all these drug-resistant strains of bacteria that don't respond very well to the antibiotics. Similar to, psychosis, it makes sense. When you feel better, you don't think you need it anymore. You think you're good, you're done, that's not going to happen again. I'll get into that a little bit more, but just regarding the progression, it's not uncommon that we see people, and they can go like months and not have any illness. They could get off the medication. The medication tends to last a little bit longer than the day they stop taking it. But we definitely see people not want to stay on the medication. They're young. Who wants to be on medication? We totally get it. But unfortunately, we also know that if you're off the medication and you engage in certain risky behaviors like substance use, or even if you don't, there's a good chance that you're going to end up eventually having another episode, especially in the first 5 years from diagnosis. That's when it's the most unstable. And that's when the cognitive decline starts to happen. So every time a person has another episode, they tend to stay longer in the hospital. It tends to take longer for them to respond to the medication. And you really do see it. Like initially, the first presentation, it might be a few days and they're already better. Generally, the second one could take weeks, sometimes months. I've seen actually people not get out of it, unfortunately, with the second one or third one or whatever. But generally, over time, you do start to see cognitive decline. So initially, they can usually get back up to where their previous functioning level was. Again, it depends on their actual diagnosis. We don't necessarily diagnose schizophrenia right off the bat. You have to have symptoms for a good period of time, over 6 months, for that to happen. But if depending on the situation, most people can get up to, I would say, 95% of previous functioning, if not more. Some people get back to normal. Depending, like I said, if you have bipolar, you're more likely to have that happen, or depression, maybe to have that happen. But there's other ones, maybe schizoaffective and schizophrenia, probably not as likely to see like a previous return. But many of our young people, they go back to school, they do what they were doing before, which is amazing. And like, it's amazing to see what people can actually accomplish. I think in the old days, we kind of just thought you're diagnosed with psychosis, you're probably not going to have much of a life. So they wouldn't give too much support. Now we know we need to tell people and show them this graph, for example. It's one of the things that I do with my clients. I'll show them that with the progression. So yeah, we don't love medication and it's not easy to be on it, but at the same time, we don't want you to decline. And so most people, when they see that, they can kind of live with it, or they're more likely to live with it. And not everyone needs medication, but the majority of the clients that we work with do actually need it. So it would be great. We know that the longer a person goes with psychosis untreated, the worse their situation is, the harder it is to get them help. It's unfortunate. But that's what we see. So that's why in the old days, when we first started early psychosis, we would do a really fast treatment. We would actually go into the hospital usually and go and see them within 3 days, usually of them being referred to us, which was the whole point of early psychosis, which I'm going to get into in a minute. But anyway, so just regarding the progression, again, everybody's varies in duration and severity. Some people really get unwell, lose everything, lose their housing, lose their job, or whatever schooling they're doing. And some people can literally, they're on a March break and they might be back to school the next week, right? Everybody's so different. And residual symptoms often persist beyond the actual episode. So often the scary symptoms, the ones where it's obvious there's something wrong, those ones respond really well to treatment. But what we find is the residual symptoms, so the negative symptoms, take longer to respond to treatment, and they linger for a bit longer. It would be great if we could predict who's going to get psychosis. There are some tools right now that they are using, which with pretty good predictability, to suggest if somebody's going to actually convert to psychosis. So it's called clinical high risk or high risk, ultra high risk, and it's based on these tools and interviews that they might do with them. So I have that information if anybody's interested in more detail. So early psychosis intervention from the 1990s is when it was first established. I believe Australia, I think Canada, probably BC, UK, Netherlands, they were suggesting that this different approach to psychosis, because it needed to change, because in the past, people did not do very well. And they found that, you know what, actually we can go back to work, we can go to school, like people will do better when they have purpose. And we have to just expect, it's the optimal kind of level of stress, right? You don't want to have too much, you don't want to have too little. You do better when you have a little bit of structure. So 1999, Epion established the early psychosis intervention in Ontario. They have a website called Epion. Informally, it was like a grassroots kind of organization, which developed into having standards, which all early psychosis intervention programs in Ontario were expected to use those standards. So the standards would include things like what our program would include. So it would have like recreational aspects. So it's important to, get people out and moving, because, sometimes weight gain is a part of the medication. So it's important to have that. Also, like for socialization and for having access to other people who are experiencing the same thing, such a huge thing. Early identification, so case finding, having people like in schools, teachers to be able to say, you know what, I know something's going on here. We would have a lot of access to schools previously. I think things have changed a lot since COVID, because a lot of things stopped, and then it just seems like they haven't started in the way they were. Also, we've probably noticed an increase in people coming in. So there's less resources, which I'm sure is across the board. Anyway, so we definitely tried our best to do this, but I know that from our program, when it first started in what year?
2007.
Yeah.
So Lake Ridge Health started theirs 2007, and I believe initially 72 hours was how long you had to see the person from referral. Now it's probably 6 months. Which is unfortunate, because it's really not truly what we call like early intervention. Early intervention is definitely the best case scenario. Education is something that we're supposed to provide to clients and to family members, because lack of insight is a big part of psychosis, anosognosia, so not really knowing that they're unwell. And so having family members be a part of it. So we often ask clients, so we don't just assume, so depending on their age, we ask clients to fill a consent form out to allow family members to have access and to be a part of their treatment. So we do provide family support, sometimes in the form of groups, definitely a lot of individual family support. And it just helps, like having one person come and get all the information. Clients don't necessarily tell us the things that we need to know. Family members are really great at reaching out when things are not going so well. And they're always usually very open to hearing what we have to say to help the situation. So it's such an important and integral part of early psychosis intervention, and I do believe it is a standard as well. Recovery oriented, so really believing in that recovery process, and very strengths based, so looking at what the clients can bring. And they are usually very remarkable people. Like I've worked with so many people, I can't even believe it. And it's surprising how far people can get. Despite having experienced this. So it's not necessarily in the old days, like if you were on this medication, that was it, because the medication was so horrible. Nowadays, the medications are way better, and they're not perfect, but they're a lot better, and functioning is usually way better as well. And not everybody needs to stay on it. So it depends again on their situation. Our program is up to a period of 3 years. It used to be 5, but resources didn't allow that anymore. And intense treatment. So depending on the stage of illness, if they're in the beginning, usually we'll see them a couple of times a week, or at least have contact a couple of times a week. But as they get better, we're seeing people like every month or 2. So, and then hopefully transitioning them into a better program, or a more appropriate program for their level of requirements. It would have been great. In the beginning, we had very low caseloads. Those are getting higher. Again, that's for another day, though. We'll talk about that another time. So basically, we try to provide low barrier access to treatments for clients. So in terms of risk factors, what predisposes a person? So high expressed emotion in home environment. So a lot of tense arguments, that kind of thing, would be a situation where you're more likely to see clients develop psychosis if they have the vulnerability. Invalidating home environment. So that's where there's, not a lot of talking about situations, not a lot of talking about feelings, not really feeling heard in their home environment. So just not a lot of communication, a lot of everybody going to their room and not really having dinners together ever or anything else. So those are the two, but again, this is just risk factors, so it doesn't mean that those will result in that. But anyway, trauma and bullying. So anyone who's experienced some type of trauma or has been bullied, obviously is an increased risk. Substance use, we definitely know, especially the use of substances at a very young age. Under 16 is definitely not the best situation. Having a family member with moderate to a severe mental health issue is definitely a risk factor. So not to say that, it increases your risk greatly, but it definitely increases the risk. We usually find that when we ask people, have you had any family members, they'll often say yes, somebody with bipolar or schizophrenia or somebody who's suicided. Loss of a parent, so either through divorce or death. Not sure that it's the loss of the parent per se, or if it's that, being raised by one parent and then having a lot of time on your hands and maybe exposed to more vulnerable situations. Don't know exactly what it is, but again, we're just kind of mentioning these because they are kind of something we've noticed. Medical conditions, so concussions. A lot of our clients have experienced concussions and more than one usually. They're often very sporty when they were younger. So don't know, but we know that it seems to be there. Or other kind of infections in the brain, encephalitis. Lack of oxygen at birth is another risk factor for developing schizophrenia or psychosis at some point in their life. So there's lots of different things. In terms of genetics, 50% concordance risk with identical twins. So that gives you an indication, of that there definitely is a strong genetic component, but yet there's still 50% of a possibility that it wouldn't happen to the other twin. So I think that in itself, to me, is very encouraging. We do believe in the stress vulnerability model. So you have to have that vulnerability in your brain, which is a predisposition for having psychosis. And because that explains why some people can go through a lot of stuff and never have any problem, and other people can go through some very stressful situation and have like a huge issue. So it obviously, if you have that predisposition and then you have this perfect storm of stressors, the time that this presents typically is in the late teens, early 20s. It tends to present a little bit earlier in males, a little bit later in females, perhaps because of, I don't know exactly what it is, but maybe it's some hormones, or maybe, I'm not sure actually, but we notice that definitely happens. And so it tends to be that females might fare a little bit better because they're a little bit later when it happens. Maybe also substance use with females might be a little bit less, I'm not sure. There's been lots of different hypotheses to explain psychosis. We definitely notice there's a lot of research on, I think there's like 200 articles about the season that you're born in. So born in winter apparently increases your risk. Honestly, I don't know that it actually makes sense to me why that would happen, because I feel like when you're pregnant for 9 months, there's a good chunk of, seasons that you're going through. So if it's related to illness, maybe there's maybe there's a developmental phase of your development that's affected at a certain time. I'm not sure. I think that is some of the hypothesis though. Urban living, so living in a city increases your risk. Again, I'm not sure why. But anyways, it's just important to notice these things. ADHD is another one, another risk factor. I think your risk is the 4 times if you have ADHD that you would have psychosis. And then I put in their chosen field of study, and this is all like this part. So a lot of this stuff comes from research that I did, but like that one is actually just anecdotal from our program. And we've noticed that we have a very high percentage of clients who are in engineering or IT. So not sure why, and healthcare. Surprisingly, we have a lot of people going to nursing. So not sure, kind of think when you look at the home environment, high expressed emotion, maybe more likely to go into healthcare. invalidating home environment, probably, maybe not so good with emotions and maybe more likely to like engineering and IT because you don't have to have so much interaction. I'm just theorizing again, just put it out there, probably not true, but
Interesting study to do.
trying to make it interesting and not so dry. Okay, so protective factors. So we can't prevent all cases of psychosis. Some are just heartbreaking. They happen so young. Typically, we see substance use with it, with the first episode, but it happens where we don't see that. And that's actually, I would say, even harder because it obviously suggests a very strong genetic predisposition. So having supportive family makes a huge difference in how people do. Having the later age of onset, obviously, the more you can accomplish before it hits, the better. Limited substance use, early treatment, healthy lifestyle, so like exercising, having balance in your life, eating well, and making sure that they get adequate sleep. So we really discourage our clients from actually doing any kind of night shift work because it has a huge impact on mental health. We know that anyway, it has a huge impact on physical health and mental, but particularly with our clients, they don't do well with a change in their sleep schedule like that. And then good coping skills. So that's why, treatment, this is where we come in, is we try to teach all of that stuff that they might not have gotten from their family. So we also encourage communication skills to be improved, which I think honestly is one of the biggest parts of the treatment that I do. And so cannabis use and psychosis. So there's a clear association of cannabis use impacting mental health. This has dated back centuries. People describing that. Increased emergency room visits for age 15 and up was found in an Ontario study from the period of January 2016 to May 2021, 190% increase. Symptoms of regular cannabis use can look like the negative symptoms of psychosis, which makes it difficult. And it also can perpetuate some of the substance use because they don't feel well and they just want to feel better. And they think that that will make them feel better. It also exacerbates their symptoms, so increases paranoia. Sometimes have panic attacks or anxiety, and anger symptoms may also worsen with the use of cannabis. Now, I do have a video which I'm not showing because we don't have time. Sorry. Okay, so we'll move right along and you can have that at some other point. So I'm just realizing the time. I wish somebody had actually shut me down. No. So I'm just going to quickly point out that it's really hard to find psychosis. In the legal system, I feel like we're probably not picking up on it. I know I've had a client that was not picked up on. He was in his late 20s when he had an episode of violence towards a grandparent. And I was the one who said, hey, did you get offered a diversion program? And he didn't. I think if they have a first offense at the age of 26, 27, that might be a good indication. Something out with the norm, something that really doesn't make sense. Or if there's some like really unusual component to it, psychosis is probably there. Like I wouldn't be surprised. I think that, just understanding a little bit more and that people with psychosis don't usually tell you they have it. And they don't want to, even if they advocate, even if that would make the best case scenario for them, they don't want to say they have it. And they are normal when they're not in psychosis. So it's really hard to pinpoint who they are. And that makes it really challenging. No, I'm going to pass you on to Jeff.
Okay.
He's going to talk in high speed.
I will go very quickly. So with our EPI standards from 2011, I remember reading this back in 2008 when I started with this team and looking at the stat of 1 in 10 people with psychosis commit suicide, 2/3 in the first 5 years of illness. And when we started, we were involved for the first 5 years. So psychosis basically takes a person out. It takes a person out of school, out of relationships. Sometimes people lose all their friends because their friends don't know, how to interact with them, or they're scared of, they went to, the hospital, they were on a psychiatric unit. And, I looked at this and I was like, holy smokes, am I going to lose, 1 out of every 10 of my clients? And the slide goes on to share, some of the other areas where psychosis affects folks, which includes incarceration and legal consequences. We can flip that one. So I'm happy to say, looking at this program, we have not seen that level of violence against self. So this is looking at a little snapshot, 17 years, and, what we have encountered. So very unfortunate. We did have a client who murdered a family member. There was definitely high expressed emotion in that household. The client was quite unwell. And these are obviously the types of situations that we're trying to prevent. And we also had a client that was murdered in an incident involving gun violence in the community. So over the course of 17 years, not a lot that we've seen. And we've seen definitely over 1,000, more than 1,000 clients over that period of time. There's been a couple of aggravated assaults that, you know, were serious assaults, but did not lead to someone losing their life. And looking at, you know, our suicide rates, unfortunately, there have been a handful of suicides across the 17 years in our program. We've heard of a couple of clients that have passed on after they've left our program as well. And sometimes it's not even understood, was this an intentional suicide or was this an unintentional drug overdose? So really feel that the early intervention is saving lives. We're making a significant difference. We're helping folks in their recovery. And also with an understanding that prevention is incredibly hard to measure, right? Because what we're talking about is events that we prevented from happening so they actually don't take place. So when we look at the stat of 1 in 10, clearly we are absolutely nowhere near that stat in our program, and very happy to be able to say that. So we'll flip the slide. So looking at when things don't go well, where folks are found not criminally responsible. This is a quote from the CEO of Schizophrenia Society of Canada at the time. Your chances are greater of being struck by lightning than being killed by an NCR person. So that's, you know, that's a good understanding that if somebody gets the right treatment, unfortunately, that right treatment typically happens after somebody's been untreated and quite unwell, and they commit a crime that is very serious in nature. So the difference of someone who is NCR and someone who goes to regular prison because they committed a crime, statistically, folks that are NCR are much, much less likely to commit a crime after they've been treated and are doing much better. There's definitely high prevalence of mental illness in the prison population. And my question is, are they getting adequate treatment or support? So we know in the community, there's a lot of options, and in prison, not so much. I added a little thing there for Cry Chair. So that's a quick little story of a previous colleague of ours, used to work at the Central East Correctional Center as an addiction counselor, and would have clients come in to meet with her privately. And in that chair, away from being in the pod amongst the other prisoners and stuff, where they had to really keep up an image of being tough and doing okay, they were able to be honest with their emotions and would often break down and cry. And I remember her saying, you know, I was looking for, you know, where were the addicts working at Pinewood, our addiction center, and she said that she found them in prison. So folks with major mental health issues, major substance use issues, and finally a place where they felt safe that they could be honest about what was happening with them emotionally. And I don't know if there's adequate services in prison to address the amount of mental health and addiction issues that they see there. This name here, Will Lee Baker. We won't do a poll to see who knows that name, but we'll move on to the other slide. So what happens oftentimes is this sensationalized headline of something horrific that happens with someone who is mentally unwell in the community. So Vincent Lee, if folks remember, murdered Tim McLean on a Greyhound bus in 2008. And he was an untreated gentleman with a diagnosis of schizophrenia. At the time, he believed he was chosen by God to save people from an alien attack. So what we know with NCR is if somebody is accused, do they have the capacity to understand that what they did was wrong? In this case, he did not, and he was found not criminally responsible for the offense. So he spent 7 years in treatment in a psychiatric unit. So it'd be the equivalent of Ontario Shores in Whitby, where there are forensic units over there. So he happened to be in Manitoba, and he was given an absolute discharge in 2017 because he'd been treated and he was doing quite well and at a low risk to reoffend. And I included included a quote by Tim McLean's mom at the bottom there. Vince Lee got help, good for him. She said, maybe he's feeling better today. My son's still dead. What if he chooses not to take his medications? We know what he's capable of. So this is the push-pull of someone who absolutely did not have the mental capacity to understand what he was doing in that moment in full psychosis was wrong. And at the same time, having an innocent victim who was murdered on this Greyhound bus. So just an understanding that these are very complicated issues and difficult to resolve to everyone's satisfaction. A couple other little stories real quick with not early intervention and early intervention. So my roommate from university, his older brother, was a brilliant gentleman. He became a lawyer and also a chartered accountant at the time, back in the early 2000s. He was one of only 50 people in Canada that had the two designations. He was very successful working for a firm downtown. I visited him, in his Bay Street condo. He drove a convertible BMW. And then with some substance use along the way, he developed schizophrenia later in life. At one time, he believed he was Jesus, and his girlfriend at the time, she had to kind of act like Mary Magdalene, and if she didn't, he would become violent. So we look at violence associated with the delusion of believing he was Jesus, and things deteriorated for him. He did not have insight. And I had actually gone to a training at CAMH back in 2018, decided I'd walk through campus again, just kind of reminiscing. And I ran into him at Bloor and St. George by the Badish Museum. And we had a little chat. So, he thinks his brother is the devil. I know that he had attacked his brother and that they hadn't talked in many, many years. And he was just kind of walking the streets of Toronto, trying to combine Einstein's theory of relativity with economic theory, and really with the goal of helping people. So he would do a chapter per block of this. And, he would say, every Monday, I wonder if it's going to be the last Monday that I have to do this. So he's a gentleman who is out on the streets, was incredibly successful. And this is a story of someone who didn't do so well with a lack of treatment and a lack of insight. I worked for the Partner Assault Response program, so men and women charged or convicted of domestic violence. And I can tell you that most violence was not related to a mental health issue. And I did that for 14 and a half years. And we would hear from our supervisor if someone was entering the program that did have severe and persistent mental illness like schizophrenia. And that was rare. One other little story. So we had a client in this program. We did the early intervention with this gentleman. And when he was at the hospital, he destroyed a room on the psych unit looking for cameras. So believed he was being monitored and was trying to find these things. And he was criminally charged. So he went in to get help and he came out with charges. Thankfully, we were able to talk to our justice partners and have those charges withdrawn. And he had another episode of psychosis before he became well, went to school, became a nurse, and now actually works on the unit that he was admitted to. So I think that's a pretty cool story of how early intervention can work out very well.
So I'm going to pick up from here and talk about the benefits of LAI therapy, which is long-acting injections. So I'm referring to antipsychotic medication. Here at the EPI program, our psychiatrists do prescribe other medications, mood stabilizers, antidepressants, even stimulants where indicated. But I'm going to keep mine to the long-acting antipsychotics because right now they're the only ones that come in injectable form, and they're the ones that our clients require for the treatment of their psychosis. Okay, so you want to go back? Yeah, sure. That's okay. So anyone prescribed a medication that comes in an injectable form, that's who we should consider for long-acting, especially those individuals who have challenges taking their oral medication for whatever reason. So often with our individuals, they are started on an oral medication to see if they tolerate it, to see if it's the best medication for them. and often what we would find is that we overestimate their level of adherence. So I got into the practice of asking them, how many times this week did you forget to take your medication? And often they'd be normalizing it, because you would find that they had forgotten on a couple of occasions, gone out to party or whatever, gone away for the weekend, didn't take their meds with them. So we want to normalize that this does happen. And it doesn't take very long or many medications missed to run into some problems, to have the psychosis come back, or to run into some problems with sleep or whatever. So, all right. So with the long-acting injections, they are administered every 2 weeks to every 12 weeks. So it actually takes away that choice every day of whether they want to take the medication or not. So most of the individuals that we are on, their medication is administered every 4 weeks. And for some of them, it's every 3 months, depending on the type of medication, which is wonderful, because it's actually only 4 times a year that they're requiring their medication. Because the medication is released into the muscle, they can have lower doses, which often equals less side effects, because we do know that all meds come with side effects. So you're always balancing the efficacy with the side effect profile and trying to, make it as tolerable as possible. With them being on a long-acting injection, it builds trust with the family, because the family's not watching to see if they're cheeking the meds. The family's not having to ask their loved one, are you taking medications? And as the healthcare providers, we know that the medication is being administered because they're coming into the office, or we've arranged for a service to go into the home to do the injection. So it also reduces the risk of relapse and readmissions, because it is neuroprotective. We, like our clients, we often sort of at the beginning tell them that they're going to be on medication for at least a year from the time that they are stabilized, that they're showing no more symptoms, or their symptoms are greatly reduced. And then we begin to kind of slowly wean them off their meds to see how they do, usually during a period of no, upheaval. So we want it to be a kind of a calm, not a period of big transitions. So the lack of insight. We recommend to all our families the book I'm Not Sick, I Don't Need Help by Dr. Amador Xavier. It estimated that 50% of those with severe mental health illnesses don't believe that they're ill. So with poor insight is associated with non-adherence with treatment and services, involuntary commitment to hospital, more complicated course of illness, and criminalization of the mentally ill. So there's a huge cost without, we're not adequately treating people with medication, because it is the cornerstone, we believe, here at the EPI program. Not all our clients will be on medication, but I estimate about 95% do. And I'd say when they leave our program, 80% are on medications. Only 20% go on to not require medications. Okay, so the negative symptoms, because we're given that choice every day to take the meds or not, you have to look at the cognitive impairment. Some individuals don't have the ability or their inability to remember or to plan ahead to take the meds. The negative symptoms, they have no motivation to take the pills. The side effects, as I mentioned, substance use is a big one as well. If they're going out drinking or whatever, meds may not be on the top of their mind. Housing and financial insecurity. A lot of our youth initially, or maybe youth couch surfing, and the cost can be prohibitive. So OHIP Plus covers up to the age of 25. So I'm going to talk about Form 2s. Families are often very much in crisis when they're trying to get their loved one into hospital. What we do here with our families is that I will send them by email a PDF, a version of an application to go get a Form 2 done, so that the family can do it at home before they go in to see the Justice of the Peace. We also provide them with a tip sheet on what information is required on the Form 2, so that they can help, get their loved one into hospital. So on the Form 2, of course, they need the evidence of a mental health illness. When did the illness begin? Description of the symptoms and the behaviors, the diagnosis, if they've already been previously given a diagnosis, what the treatment plan is, if any, the level of their compliance with their treatment plan, the last visit they were seen with the doctor, hospital admissions, anything. we want as much detail as possible. Any danger to themselves or others, any threats, be it verbalized or gestured, any talk of self-harm or suicide, violence, property damage, substance misuse, we want it all down. And any indication of failure to care for themselves, the refusal of meds or food or nourishment, weight loss, not tending to basic hygiene, inappropriate clothing for the weather, not able to manage their affairs or looking after their health conditions like infections or whatever, and any other concerns that they may have regarding their loved one. Okay. Okay, so anyone, although most often it's a family member who believes an individual requires mental health care, can go to the Justice of the Peace to get a Form 2 to have their loved one taken to the hospital. The information, of course, is presented before the Justice of the Peace. The Justice of the Peace determines if the criteria is met, box A or box B. Box A being that the person is unwell, they're a threat, or attempting to harm themselves or someone else. And box B is that they previously received treatment for a mental health disorder that's of an ongoing, recurring nature. Again, that's why we want families to put all the information down that they can. Now, the Form 2 is delivered to the police, and of course, there is 7 days, including the day that it was issued, for the individual to be taken either to the ER department of a Scheduled I facility, that's where someone can be detained against their will, or a physician's office. And we have had people brought in here to have their injections done, and then they're on their way. Individuals may be detained for up to 72 hours. After that 72 hours, they need to be, or during, at any point at that time, they can be released back into the community, or they can be put on a Form 3, which will keep them for another 2 weeks. Okay, so we do have programs that kind of help. We have community treatment order programs that allows for a person with a serious mental health illness to receive care and treatment in the community versus a hospital setting. The one criteria is that the hospital psychiatric admission they must have for over 30 days in the past 3 years, or 2 psychiatric admissions in the past 3 years. Okay, or it could be an individual that's in hospital that agrees to having their treatment in the community. You're going to ask me here, sorry.
I'm just looking at the time.
Okay, all right. So the community treatment is devised with the client. So there's an expected adherence to their treatment plan, and it needs to be physician referred. And at the end of the CTO, the person can after 6 months, it is reviewed, and they can say they don't want it. We also have the ACT team, the Assertive Community Treatment Team. And they need the predominant diagnosis of schizophrenia, schizoaffective disorder, bipolar. Okay, so and often these individuals do have coexisting concerns like homelessness, substance misuse, involvement with the legal system. So there has to be a serious impairment to role functioning, frequent hospitalizations, 50 days or more in hospital for a psychiatric reason over the last 1 to 2 years. And the ACT team is a very comprehensive care. It's by a multidisciplinary team. There's social worker, nurses, psychiatrists, OT, vocational therapists, peer supports. They'll see a person twice a day to every day, as often as the individuals need to keep them well in the community, functioning to their success. Okay. Again, they also have to be willing to be part of the CTO program. So you can see inherently where the problems are if you're dealing with an individual with anosognosia, which it is believed that 50% of those with severe mental health illness don't believe that they're unwell, and then getting them to agree to take medications or agree to follow the ACT team or CTO recommendations, or even to come into our program, which is voluntary, can sometimes be quite a challenge.
That's it.
Okay.
All right. Sorry that we didn't leave too much time for questions, if any.
I'd like to thank you, all 3 of you, for presenting today. That was very informative. Myself, working in addictions and mental health, I learned a lot. There was one question, and the question was, will you be able to share the PowerPoint presentation?
Yes,
absolutely.
Awesome. Perfect. So for anyone that's been here, I will ask the presenters to email it to us, and then we can send it out when you get a copy of the presentation. So I don't know if there's any other questions. I don't know if I'm not seeing any, but definitely some positive feedback for you guys. And I want to thank you on behalf of the Association of Justice Treatment Professionals for providing this session for us today.
Well, thank you. And thank you for listening. And thank you for having us. That was great. Nice to see you.
Bye.
Take care. Bye.
Bye.
Yep.